Congenital heart diseases. Criteria to suspect congenital heart diseases are cyanosis since birth, murmur since birth, no history of rheumatic fever, recurrent chest infections, hypertensive child, positive family history, associated congenital anomalies. Classification: we have cyanotic and acyanotic. Cyanotic such as Fallots tetralogy, Fallots triology, tricuspid atresia, transposition of great arteries, and Eisenmenger syndrome. Acyanotic with right ventricular enlargement, ASD, and pulmonary stenosis, with left ventricular enlargement, aortic stenosis, PDA, coarctation of aorta, with biventricular enlargement, VSD, ventricular septal defect, with no ventricular enlargement, any mild lesion, and dextrocardia. Atrial septal defect anatomy: there is an abnormal opening between the two atria, producing left to right shunt. High ASD, ostium secundum, this is the most common. Low ASD, ostium premium, which may be associated with mitral valve disease, Luttenbacher syndrome. Important MCQ note. Hemodynamics: as the pressure in the left atrium is higher than the right atrium, blood is shunted from left to right atrium, then right ventricle, causing right ventricular enlargement, and finally PA causes the pulmonary aorta, causing its dilatation for the lung, increased blood flow through the pulmonary arterioles, leading to lung plethora and then pulmonary hypertension. The blood from lung comes back to the left atrium and the cycle is repeated. Notice that the blood passing from left atrium to the left ventricle will be less than normal, leading to low cardiac output. So in atrial septal defect we have low cardiac output, right ventricular enlargement, and lung plethora. Clinical picture: symptoms asymptomatic in mild cases or in early life, symptoms of hemodynamics, symptoms of low cardiac output, and symptoms of lung plethora, exertional dyspnea and recurrent chest infections, symptoms of complications, symptoms of associated congenital anomalies such as secundum ASD may be associated with triphalangeal thumb and radial abnormalities. Signs: no signs in mild cases, signs of hemodynamics, signs of low cardiac output, and signs of lung plethora, signs of complications: neck vein, no giant A wave in spite of pulmonary hypertension. Cardiac examination: right ventricular enlargement, auscultation, S2 is accentuated, wide fixed splitting of S2, accentuated and wide splitting due to pulmonary hypertension. It's fixed because the increased venous return to the right atrium during inspiration is compensated by decreased blood shunted from left atrium to the right atrium. Murmur of relative tricuspid stenosis, pulmonary stenosis may be heard, or no murmur of ASD itself because of the low pressure gradients between the two atria. Additional sounds: ventricular gallop due to right-sided heart failure. Complications: right-sided heart failure, paradoxical embolism, stroke, Eisenmenger syndrome, cyanosis with shunt reversal, infective endocarditis, rare due to low pressure gradient, arrhythmia, atrial fibrillation. Investigations: X-ray, right ventricular enlargement, dilated pulmonary artery, lung plethora, ECG, RBB, right bundle enlargement, I can't remember the name in most cases, right ventricular enlargement, echo, right ventricular enlargement to detect the defect, catheterization, detect the defect. The catheter may pass through the ASD, increased pressure in the right side of the heart, and increased oxygen level in right atrium in comparison to superior and inferior vena cava. Treatment: closure of the defect must be done before reversal of the shunt, and treatment for complications. Pulmonary stenosis anatomy: valvular, the most common type, 80%, subvalvular, infundibular, or supravalvular, which is rare. Hemodynamics: pulmonary stenosis increases the resistance, so it increases after load against right ventricle, leading to low cardiac output and right ventricular enlargement, then failure. Clinical picture: symptoms asymptomatic in mild cases, symptoms of hemodynamics, low cardiac output, and right-sided heart failure. Signs: general, signs of low cardiac output, signs of right-sided heart failure, giant A wave. Cardiac: right ventricular enlargement, systolic thrill on pulmonary area, auscultation S2, weak pulmonary component of S2 with wide splitting. Additional sounds: ejection click in valvular type, S4 on tricuspid area, murmur ejection, systolic murmur on pulmonary area. Complications: right-sided heart failure, infective endocarditis, TB due to lung oligemia. Investigations: X-ray, right ventricular enlargement, lung oligemia, post-stenotic dilatation in valvular type. ECG, P pulmonaire, right ventricular enlargement. Echo is diagnostic. Catheterization is diagnostic. It detects pressure gradient across the pulmonary valve. If it exceeds 50, then this means severe pulmonary stenosis. Treatment: prophylaxis against infective endocarditis, treatment of right-sided heart failure, surgical in severe pulmonary stenosis. For the valvular type, valvotomy or replacement. Subvalvular, resection of the infundibulum. Patent ductus arteriosus or PDA. Anatomy: persistent ductus arteriosus between the left pulmonary artery and aorta just distal to the left subclavian artery. PDA is normal during fetal life and it closes soon or shortly after birth. PDA is common in premature babies, particularly in female infants. Hemodynamics: the aortic pressure is higher than the pulmonary pressure. The pulmonary pressure is 20 over 10 millimeter mercury in both systole and diastole. So the blood is shunted from the aorta to the pulmonary artery in both systole and diastole, leading to increased blood flow to the pulmonary arteries, lung plethora, increased blood flow to the left atrium, left ventricle, leading to left ventricular enlargement, then failure. Then the aorta will have high cardiac output, high systolic blood pressure. The escape of blood from the aorta to the pulmonary artery leads to low diastolic blood pressure. So high systole and low diastole leads to hyperdynamic circulation and big pulse volume. Later on, pulmonary hypertension and reversal of the shunt, leading to Eisenmenger's syndrome. Clinical picture: symptoms: no symptoms in mild cases. Symptoms of hemodynamics: symptoms of lung plethora, symptoms of hyperdynamic circulation, palpitation and general throbbing, symptoms of complications and symptoms of other congenital abnormalities. Signs: no signs in mild cases. Signs of hemodynamics: lung plethora and hyperdynamic circulation. They are the same as the peripheral signs of aortic regurg. Signs of complications: neck vein, giant A wave due to pulmonary hypertension. Cardiac examination: left ventricular enlargement, continuous thrill over left intraclavicular area, which is the site of ductus arteriosus. Auscultation: S2 is accentuated with reversed splitting due to delayed evacuation of the left ventricle. Murmur: continuous machinery murmur over the left infraclavicular area. Differential diagnosis of continuous murmur: arteriovenous fistula, PDA, coarctation of aorta, double mitral, combined mitral stenosis and mitral regurg. Complications: left-sided heart failure, paradoxical embolism, stroke, infective endocarditis, arrhythmia, and Eisenmenger syndrome. Differential cyanosis: cyanosis only in lower limb because of the reverse cyanotic blood enter aorta distal to the subclavian artery. Investigations: X-ray, dilatation of the aorta, as well as dilatation of the pulmonary artery, left atrium and left ventricle, lung plethora. ECG, we have left ventricular enlargement. Echo, we have chamber dilatation. Catheterization, it detects the defect. The catheter may pass through the PDA. Increased pulmonary pressure, increased oxygen level in pulmonary artery in comparison to the right ventricle. Treatment: medical prophylaxis against infective endocarditis, treatment of complications and medical closure of the duct by endomethacin, surgical closure of the duct. Coarctation of aorta: congenital narrowing of a part of aorta distal to left subclavian artery, associated congenital anomalies, bicuspid aortic valve, aortic stenosis or aortic regurg, PDA, VSD, congenital aneurysm of circle of Willis, Turner syndrome. Hemodynamics: narrowing of part of aorta leads to increased blood pressure in proximal part before narrowing, decreased blood pressure in distal part after narrowing, development of collaterals between proximal and distal part. Clinical picture: symptoms: asymptomatic in mild cases. Symptoms of hemodynamics: increased blood pressure in the upper half, symptoms of hypertension, headache, epistaxis, decreased blood pressure in the lower half, fatigue, intermittent claudication of the lower limb. Collaterals: pain around left shoulder. Symptoms of complications: symptoms of other congenital anomalies. Signs: no signs in mild cases. Signs of hemodynamics: increased blood pressure in arms, prominent carotid pulsation, decreased blood pressure in legs, weak pulsations of the lower limb, dorsalis pedis, for example. Collaterals may be seen in the interscapular area, Sussman's sign. Signs of complications: signs of other congenital anomalies. Cardiac examination, left ventricular hypertrophy, auscultation, accentuated S2, murmurs, ejection, systolic murmur due to coarctation itself, below left infraclavicular area, associated aortic stenosis and hypertension, early diastolic murmur due to associated aortic regurg, continuous murmur over collaterals, complications of hypertension, cerebral hemorrhage, heart failure, infective endocarditis, investigations, X-ray, left ventricular enlargement, Rosler's sign, rib notching from the 3rd to the 8th due to erosion by collaterals, ECG left ventricular enlargement, echo left ventricular enlargement, which can detect the coarctation, catheterization and aortography detects the site and severity of coarctation, treatment, medical, prophylaxis against infective endocarditis and treatment of complications, surgical repair in early childhood to avoid persistent hypertension. Ventricular septal defect. There is an abnormal opening between the two ventricles producing left to right shunt. There are two types, big membranous type. It occurs in the membranous part of the interventricular septum. Small muscular type, Rogers disease. It occurs in the muscular part of interventricular septum. Hemodynamically insignificant and more than 90% of cases close spontaneously. Hemodynamics, the pressure in the left ventricle is 120 over 0 millimeter mercury. The pressure in the right ventricle is 25. So the blood is shunted from the left ventricle to the right ventricle during systole only. The shunted blood to the right ventricle leads to right ventricular enlargement, increased blood flow to pulmonary arteries, lung plethora, pulmonary hypertension, increased blood flow to the left atrium to the left ventricle leading to left ventricular enlargement, later failure. Notice that the blood passing from left ventricle to the aorta will be less than normal, so low cardiac output. So in VSD, there are lung plethora, biventricular enlargement, low cardiac output, clinical picture, symptoms asymptomatic in mild cases and in Rogers disease. Rogers is the small muscular type of VSD. Symptoms of hemodynamics, lung plethora, exertional dyspnea, recurrent chest infection, symptoms of low cardiac output, complications and other congenital anomalies. Signs, no signs in mild cases. Signs of hemodynamics, lung plethora, low cardiac output, signs of complications, neck vein, giant A wave. Cardiac examination, biventricular enlargement with hyperdynamic apex. Auscultation, S2 accentuated pulmonary component, wide splitting, murmur, harsh pansystolic murmur with shrill over the 3rd, 4th intercostal spaces, ejection, systolic murmur of pulmonary hypertension, subaortic VSD may be associated with aortic regurg, mid-diastolic murmur of relative mitral stenosis, increased blood flow across the mitral valve, complications, infective endocarditis, heart failure, paradoxical embolism, Eisenmenger syndrome, usually at the 2nd to 3rd decade of life. Investigations, X-ray, biventricular enlargement, lung pressure, ECG, biventricular enlargement, echo, biventricular enlargement and diagnosis of anomaly. Catheterization, increased pressure in the right ventricle and pulmonary artery, increased oxygen level in the right ventricle in comparison to the right atrium. Detect the defect, the catheter may pass through the VSD. Treatment, prophylaxis against infective endocarditis, treatment of complications, surgical closure, enlarged defect, tetralogy of Fallot, slight deviation of upper part of interventricular septum to the right, leading to pulmonary stenosis, subvalvular, mild right ventricular enlargement, VSD not significant, and overriding of aorta. Hemodynamics, pulmonary stenosis, deoxygenated blood passes to aorta, leading to pulmonary oligemia and central cyanosis, mild right ventricular enlargement because the right ventricle has two ways, stenosis, pulmonary artery and wide aorta. Overriding of aorta, it receives blood from both ventricles leading to central cyanosis. VSD is not significant, it's silent despite big VSD because the pressure in both ventricles are equal. Clinical picture, symptoms, central cyanosis since birth or shortly after, central dyspnea, hypoxia due to, hypoxia will stimulate the respiratory center, clubbing, cyanotic spells, increased cyanosis with exertion. Exertion leads to sympathetic stimulation leading to spasm of subvalvular tissue infundibulum of the right ventricle, severe pulmonary stenosis, increased deoxygenated blood flow to aorta, increased cyanosis. Clinical picture, cyanosis, convulsion, cardiac arrest, Squatting position, kinking of the femoral artery, increases the resistance of the aorta, decreases blood flow from right ventricle to aorta, more blood to the lung, decreasing the cyanosis and dyspnea. Signs: central cyanosis, clubbing, stunted delayed growth, neck vein dominant A wave. Cardiac examination, slight right ventricular enlargement may be present, auscultation accentuated S2 due to increased aortic flow, single pulmonary component is very weak to be heard. Murmur, ejection systolic murmur of pulmonary stenosis, no murmur of VSD because it's not significant, silent VSD. Complications: cyanotic spell, paradoxical embolism, pulmonary TB due to lung oligemia, and polycythemia due to hypoxia. Investigations: echo and catheterization are diagnostic. ECG, right ventricular enlargement, X-ray, boot-shaped heart, narrow base with elevated apex, pulmonary oligemia. Treatment of cyanotic spell, squatting position, oxygen beta blocker, prophylaxis against infective endocarditis, Blalock tossing operation in acquired PDA, and surgical total correction. Triology of Fallot, pulmonary stenosis, valvular, marked right ventricular enlargement with ASD. And finally, we have the Eisenmenger syndrome. It's a condition in which left to right shunt in the heart causing pulmonary hypertension, which in turn leading to increased pressure in the right side of the heart and reversal of the shunt into right to left shunt. Etiology: VSD, PDA, ASD. Eisenmenger complex was applied to patients with reversal of shunt in cases of VSD by Dr. Victor Eisenmenger in 1897, but the definition was extended by Dr. Paul Wood to include shunts of any level. Unimportant information, I'm sorry that I have said it. Clinical picture: history of congenital heart disease, VSD, PDE, ASD, pulmonary infection and hemoptysis, clinical picture of pulmonary hypertension, clinical picture of right-sided heart failure, decreasing the original murmur of the shunt due to low pressure gradient. Treatment: prevention is the best. Closure of the defect is contraindicated because it will increase the pressure in the right side of the heart. Symptomatic treatment of heart failure and heart-lung transplantation. Transposition of great vessels, TGA. The position of aorta and pulmonary artery is reversed, so this leads to two separate circuits. The aorta arises from the right ventricle, so most of the blood returning to the heart from the body is pumped back through the aorta without going to the lung. Central cyanosis. The pulmonary aorta arises from left ventricle, so the blood returning from the lung goes back to the lung again. To maintain life, associated ASD, VSD, PDA, or pulmonary stenosis should exist. Treatment: keep the PDA by prostaglandin E1 and surgical correction. Dextrocardia, deviation of the heart to the right. It may be congenital or acquired. Situs inversus totalis, mirror-like transposition of the heart and all viscera. Isolated dextrocardia, mirror-like transposition of the heart only. Dextroversion, the heart is displaced to the right ventricle remains to the right, and the left ventricle remains to the left. Acquired dextrocardia, acquired displacement of the heart, usually due to fibrosis. And this concludes the congenital diseases.